This is what I'm going to kind of go through today, and then next Thursday we'll go ahead and kind of put this all together to see how it fits in. We know that pulmonary artery pressure monitoring is done through a pulmonary artery catheter, also called a Swan-Ganz catheter, although like Kleenex and Xerox, that's more of a trade name. It's also been referred to as the balloon tip flow directed pulmonary artery catheter, the BTFD PAC, MOUSE. Developed in the early 70s. It's made of polyvinyl chloride, and it has markings on it that are 10 centimeter markings as it goes from the tip. The right ventricle then lies at about the 20 centimeter point. So let me pass that around to look at. This is actually one that has an extra lumen from the conventional one. But if we look at it, there's 4 primary lumens, and so 4 ports that are connected to that. I'm sorry. 1 is for the balloon, 2 is for proximal. The proximal port lies someplace near the right atrium when properly placed. The distal refers to the distal point, and the thermolution, which basically has a thermistor bead at the very close to the very tip that measures temperature continuously. So I have my proximal lumen emptying here, my distal lumen emptying here, my balloon, and then my thermistor beads. Those are the 4 components. This one happens to be one where I can do AV sequential pacing. So not only does it have the ability to be a PA catheter, to do all the stuff PA catheters do, but it also acts as a pacemaker. In fact, it acts as an AV sequential pacemaker. Paces the atrium, waits a moment, paces the ventricle. Okay. So in that case, you end up having, or you don't lose the atrial kick that you get at 30% of cardiac output that is or 30% of right ventricular or left ventricular filling that occurs from the atrium conducting. Okay. There's my distal, there's my proximal, there's my balloon, and there's my thermistor. Stuff we can measure with a PA catheter, certainly the 2 preloads. We can look at pulmonary artery pressure being displayed continuously, and when we inflate the balloon to wedge it, we can get our wedge pressure. We can also, from the PA pressure, generate a mean pulmonary artery pressure, and as we'll find, the thermolution cardiac output is one mechanism by which we can measure cardiac output. Some catheters, not this one, but some catheters also have the ability to monitor SVO2, which really comes in handy to see when patients have alterations in their oxygen utilization. If we do draw blood from the distal lumen, that is true mixed venous blood. If you do draw it, though, the key part to remember is that you want to draw very, very slowly. You can actually arterialize or capillarize, whatever. You can actually get blood that is from a pulmonary capillary if you draw it too fast. So you actually get a little bit of a higher PO2 than realistically you would have. You can also use PA catheters, and the one I'm passing around is an example of it where it has an extra lumen that is there, an extra proximal port, so we can infuse more additional IV fluids or medications. We talked about pacing catheters. They can be used to diagnose intracardiac shunts and can help differentiate cardiac versus pulmonary. From the distal lumen, we're going to measure the pulmonary artery pressure and the mean, and when it's inflated again, we measure the wedge, and we talked about all of this. We can use that mixed venous blood then to go ahead and calculate a venous oxygen content difference, the shunt equation, Yahoo, as well as the Fick equation. Proximal port,
Again, we said it lies in the right atrium and therefore measures CVP. This is where, when we're doing a thermodilution cardiac output, we inject the fluid that we're using as a measurement technique into the right atrium through the proximal port. Okay. The balloon lies about 1 to 2 centimeters from the tip. When it's inflated, obviously with about 1.5 milliliters. Well, the capacity is 1.5, but you really don't need much more than 0.8 milliliters to inflate it to get a wedge. And you remember, you don't want to leave it inflated for prolonged periods of time, because you basically are not perfusing that anything distal to that balloon. And then the thermistor bead that is there runs back to the cardiac output machine. And what we do is we inject 10 milliliters of saline or D5&W into the proximal lumen, and we see to what extent the temperature drops by the time it gets to the distal portion of that catheter. If we have a SpO2 monitor that is there, there's a fiber optic portion on it. It uses, instead of having photo spectrometry like a pulse oximeter has, this is a reflectance technology where it bounces the light off the hemoglobin and reads what comes back. So it's got a kind of a different technique that is there to be able to monitor SpO2 on a continuous basis. Here's an example of where you have a transmitting and a receiving diode that basically will be able to interpret how much oxygen is saturated with, or how much of the hemoglobin is saturated with oxygen. We put these in really any large vein, although you don't really use the antecubital that often. Subclavian, jugular, femoral are probably more often where you'll end up seeing them placed. You can do it under fluoroscopy, but most of the time it's just done at the bedside, watching the pressure changes as it's been inserted. Has anyone ever seen one of these inserted? Is that a curiosity? You see them? Okay. So we go ahead and prep the catheter by putting some saline in it. We go ahead and test the balloon, and we just watch it as it floats in. And the balloon is inflated, so it's in the right atrium. We have a CVP pressure. Once it crosses through the tricuspid valve, I now see a ventricular tracing with a very high systolic, or a higher systolic, and a well-defined diastolic on the order of 25/0. Once it passes into the pulmonary artery, the pulmonic valve closes, and you end up having a change in diastolic but no change in systolic, as well as the development of a dicrotic notch. And then when it's wedged, again, you get a wedge tracing that has a value somewhere between 4 and 12 millimeters of mercury. And just another picture of that same exact thing. Normal values, these are all ones we've seen before, so it shouldn't be anything new, but again, I will provide normal values for you on the test. They're not without problems. Cardiac arrhythmias are quite frequent, especially on insertion. In theory, you could perforate a wall, septum, infection, thrombosis, pulmonary infarction. That would not be good. I've actually not seen, but I've heard of cases where the catheter actually wrapped around itself and knotted, which means you ain't going to be taking it back out. You got to go in and surgically remove it. Not a good deal. Westermarck sign. This is a situation where you end up having an embolism. So a PA catheter that's malpositioned will create an area where you have a pulmonary infarction. It can also happen if the catheter becomes obstructed in itself, gets a clot forming on it, and has an embolism generated from that. And here's an example. If you look at the lung here, there is no vasculature continuing out like you see on the left-hand side. So this is showing that there's no perfusion. That's called Westermarck sign. Just as an FYI. Normally we see the pulmonary artery with the dichrotic notch. In theory, and I don't expect you to know this, but in theory, both the CVP and the wedge tracing, both of them have actual changes in waveforms. So if we look back here, we end up seeing there is a little bit of a pattern here to that. And if we were to mark it out, it has what we call an A, a C, and a V wave. A being the atrium contracting, in this case the wedge pressure being the left atrium, C being the bulging of the mitral valve that you end up having, and then V the filling of the left atrium.
And it's important that we know what
No.
you don't, okay.
No. Same is true on the CVP tracing. You should actually see those three waveforms occurring.
Okay.
But no, I don't care that you know A is for this, C is for this, V is for this. In fact, I don't even care that you know that A, C, and V exist. Do I?
Yeah.
Oh, good. There you go. So answer it.
I did.
Okay. So there's my dichrotic notch, and again here you can end up seeing how it ties to the ECG tracing. So as the atria contract, I end up having a little rise in pressure, and then as the mitral valve closes, there's a small amount of back pressure that is there, and then as the ventricle fills during diastole, you end up seeing that pressure rise back up again. Normal value for PA pressure is 25/8, mean of 10 to 20. It's the afterload of the right side of the heart, if you remember. Where we see an increase in pressure is usually due to either hypervolemia, too much fluid on board, a problem with the pulmonic valve will give you an increased PA pressure. And we'll see it with left heart failure. But most importantly, we see it with the condition of pulmonary hypertension. Pulmonary hypertension can be secondary to COPD, as we see with cor pulmonale. It can also be present as an elevation secondary to pulmonary embolus, or it can be idiopathic. We don't know why, but there are patients who have, just like patients develop systemic hypertension, they develop pulmonary hypertension. Okay. And we'll talk about a little bit later about a drug that we can utilize as an inhaled agent that actually treats pulmonary hypertension. This is just showing why with PEEP you end up having pulmonary artery pressure rising because you overdistend the alveolus potentially, compress the capillaries and don't allow blood flow through, drives the PA pressure up. Low PAP would be something we would see with hypovolemia. You could also see it because the right heart has an infarction and you end up having right heart failure and there's not pressure generated by the right ventricle. COPD, we said, will often have pulmonary hypertension, especially towards end stage. If we see a normal PA pressure, there's something wrong. So if I see this picture here, I would say this patient, even though the PA pressure is normal, this is a case of somebody being profoundly hypovolemic. Wedge pressure is low, CVP is low, blood pressure is low, cardiac output's low, or cardiac index in this case. Normal wedge 4 to 12, we know it's the left ventricular filling pressure. Truly it needs to be in zone 3, which in most cases it is, to measure the left heart. Remember, that's an area where perfusion is not reduced. Zone 1, on the other hand, would be one where the alveolar pressure exceeds the pulmonary artery pressure and blood flow is significantly reduced. In most cases, it's in zone 3 without too much trouble. And it's just saying, again, the wedge pressure, the pulmonary artery pressure is greater than the wedge pressure, which it truly should be. You can confirm it with a lateral chest x-ray if you desire. But usually you'll end up seeing the diastolic pressure being just slightly higher than the wedge pressure. Now, when you have PEEP present, it's going to affect your accuracy of your wedge pressure. So first of all, wedge pressure should always be evaluated at end inspiration, so you don't have the effect of positive pressure. Some people advocate taking them off the ventilator to measure. The problem with that is you lose any recruitment that you secured from doing the PEEP. So let's say I have, and basically the wedge pressure changed by less than half of what the PEEP level is. So if I have 0 PEEP and the wedge is 14, I add 5, I would expect that to go up by no more than 2.5. So yes, PEEP will affect the value that you end up having. It's not terribly significant, but roughly half of whatever PEEP you add. If I have a high wedge pressure, it's a sign of hypervolemia. The assumption here also is that my mitral valve doesn't have any problems. If I have a prolapsed mitral, it's going to affect the accuracy of that wedge pressure and make the value be incorrectly high. If I have a low wedge pressure, it's hypovolemic. And we'll see that as we'll find in septic shock, where I end up having huge systemic vasodilation. If my balloon doesn't work anymore and it won't wedge because the balloon has become ruptured, I can use the diastolic pressure as an approximation. It's usually within a few millimeters of mercury of the wedge pressure. Excuse me. And again, these are some of the instances where you end up having where the wedge pressure lies to you. Mitral stenosis, mitral insufficiency, and high peaks are probably the biggest ones. Talk about measuring end exhalation. Normal situations, we want to have that wedge pressure being between 4 and 12. We'll find that in patients who have acute MIs where they have huge loss of ventricular muscle mass, will actually drive that wedge pressure up to an elevated level, somewhere about a range of 15 to 18, to try and improve left heart compliance and try to get a better cardiac output secondary to that. So if you have a patient who's a fresh MI, especially an anterior MI, and their wedge pressure is 17, 18, that's okay. That's a desired. Now going higher than that, you run the risk of putting them into pulmonary edema. Going lower than that, their cardiac output's insufficient. So it's a very fine line that you'll walk with these folks until they get stabilized. Pulmonary capillaries, we know that there's 2 types of pressures that are there, the osmotic pressure and the hydrostatic pressure. Hydrostatic pressure is the wedge pressure, so it's somewhere on the order of 4 to 12, and it's going to push fluid out of the vascular space and into the interstitial space. Colloidal osmotic pressure, due to plasma proteins, mainly albumin and hemoglobin, pull the fluid back in, so there's this balance that exists. If I'm in pulmonary edema, it's one of these 5 reasons. Either the hydrostatic pressure has been increased, a high wedge pressure, which we would consider cardiogenic pulmonary edema. I can also be in pulmonary edema because of reduced osmotic pressure, so somebody who's malnourished with an albumin level that's profoundly low or very anemic, you can end up having fluid leaking out of the capillary because there's nothing to hold it in. We can see this with destruction of the alveolar capillary membrane. This is what the problem is with ARDS, and that we end up having that capillary become far more permeable, and you end up having fluid leak out. In theory, something going on with obstruction of the lymphatic drainage, so if there's some tumor that is there, you can end up with a pulmonary edema secondary to that, and you can have it secondary to decompression, which is to end up seeing a lot of times with when you reinflate a pneumothorax too quickly, or I don't say reinflate too quickly, but you can end up having pulmonary edema secondary to that. Normally the wedge pressure is significantly above 20. and that's causing the fluid then to leak out of the vessel. In cases where your osmotic pressure is reduced to begin with, you can get it at a lower level. And again, we see that with kidney and liver disease and malnourishment being there. This is just showing the balance between them. Net effect is that you end up having about a 1 torr movement of fluid into the interstitial space, which is then drained by those lymphatics. And again, cardiogenic versus non-cardiogenic. Cardiogenic will always have an increase in wedge, increase in heart size, increase in pulmonary vasculature on a chest x-ray, where non-cardiogenic, aka ARDS, will have a normalized heart, normalized wedge. Different ways we can measure cardiac output. Normally we end up with thermal dilution, which is the most common one we end up using. We take 10 milliliters of either very cold or room temperature saline, inject it into the proximal port of the PAC. The thermistor then measures how much change in temperature there is once it gets to that distal portion of the catheter, and then it goes ahead and calculates out a cardiac output. The greater the temperature drop, the slower the cardiac output. Okay, so in other words, if that cold solution we're putting in mixes with the blood and drops the blood's temperature, then it's a very slow cardiac output. If there's little change, a very fast cardiac output. Does that make sense? Okay. So here what I'm doing is I'm injecting it into the proximal. I'm measuring the temperature change once it's passed all the way through, because I inject it here, it exits in the right atrium, mixes with the blood, causes the temperature to drop until I measure it. You can also use this value in calculating oxygen content. If I know the content differences, multiply my cardiac output, I can develop or calculate out the oxygen consumption. And I can index that value if I use cardiac index instead of cardiac output. This is the Fick equation. This is the gold standard for measuring cardiac output. And by that I mean I would just rearrange that equation, measure oxygen consumption, measure the content difference. I can go ahead and calculate out the cardiac output. We know about oxygen delivery. Can I tell you that we can index that too? Oh, good God in heaven. We don't normally do it. But. So normal value is about 1,000, and oxygen consumption, that's not right. Forget that last line. Well, you get the normals anyways. Using the mixed venous value, we can also derive the oxygen extraction ratio. Normally about 25% of the oxygen in our arterial system is utilized by the tissues. The other 75% is surplus. And there's my oxygen consumption divided by the content difference times 100. It'll give me cardiac output. You can do the math there. This is just showing the Fick principle, that there's some amount of oxygen that is utilized by the tissues, and then we can look at what comes back. Ejection fraction is basically the percentage of what was in the ventricle prior to contraction that actually is pumped out. Normal ejection fraction is about 65 to 70%. And we evaluate this through echocardiography. I have a buddy who's horrendous. He was in his early 40s and he had this like huge, massive MI. And his dad, his uncle, none of them lived to 50. Died of huge heart attacks, so he just like had horrible genes. But his ejection fraction, last time I talked to him, was about 25%. Not much you can do. Sit around all day. We can also use these to determine intracardiac shunts. I draw blood from the proximal, I draw blood from the distal, and I take a look at their PO2s. If PA blood has a greater PaO2 than the atrial blood, I have a left to right shunt going in. In other words, it's mixing back in to the ventricle compared to the CVP measurement. Normal saturation SpO2 70-75%. You guys know that. Normal venous values. I think we've been through these before. That's good. And we should know that the alteration in or the relationship between cardiac output and the oxygen content difference is that they're inversely related. This is the truck fruit truck going through the neighborhood. If more is extracted, it could be because the cardiac output is too slow. Lastly, I just want to talk about non-invasive cardiac output monitoring. This is kind of a new technology that's out there using esophageal Dopplers. Basically, we put a probe into the esophagus. It's then rotated so that we end up having the portion of the catheter that has these ultrasound emitters. It's basically somewhere in the descending, or when it's in the esophagus, it's pointing towards the descending thoracic aorta, and we can look at the waveform and tell if we're in the right spot, and we can measure all of these values non-invasively or less invasively. I guess truly it is still non-invasive if you're putting a catheter down somebody's nose. And this gets back to this law of continuity we talked about in 1060 over a long time ago. If you remember, the flow is equal to the cross-sectional area times the velocity. So if I know what the velocity is instantaneously through ultrasound, and I have a rough idea of what the cross-sectional area of that vessel is, I can go ahead and determine the cardiac output. Problem with the technology is we're making the assumption that the cross-sectional area of a person, we determine that based upon their height and their gender. That may or may not be true. If somebody has a calcified aorta or something else where perhaps you have a aortic aneurysm, that measurement's going to be off in that case. But it is a good technology. And basically we're just using the same exact rule. Instead of using gas, we're using blood flowing through a vessel, and we can determine it. Vaguely remember this as far as how we would end up calculating it. But at any rate, so here's what the waveform would look like. You can see the catheter pointed down. There's ultrasound that is pointing at the aorta, and I'm measuring that pulsatile flow, or the instantaneous velocity that is present, and I can from that derive it. There also is another technology. Instead of having a catheter go down, even easier, we just place a little a probe right above, right at the sternal notch, and as you point it there, you can actually get an idea of what the flow through the aortic arch is. And if you get a pulse oximeter attached, it'll actually then go ahead and give us a quantitation of oxygen delivery. Pretty cool technology. Does that make any sense to you? Okay. Let me stop there, and then we'll pick this up and talk about